that.
Yeah. So we'll move on for the next talk. So the next speaker actually doesn't require any introduction. He is considered as father of ID in India. Dr. Chandra, who is an inspiration for all of us, even at his age, he still inspires, full of energy. And he is going to talk about something which he is passionate about, antifungal drugs. He's going to talk about antifungal stewardship. Sir, over to you, sir. Want to
Okay.
share your slides?
Actually,
Yeah.
Dr. Kavita is going to help
Our
me.
team will share the slides. Jocelyn,
Yes,
please.
yeah, please go ahead. So yes, the topic I was asked to talk about is antifungal stewardship. It's not going to be with a lot of clinical examples, as you saw in the previous lecture, beautifully given by the speaker, Venkat. But this is going to be kind of a boring topic, okay? Antifungal stewardship. But I think it's a fairly important topic, especially with the Antibiotic Awareness Week that we are celebrating now. And there is a lot of abuse of these antifungal agents. There is a lot of unknowns among the practitioners. So hopefully this would shed some light. Most of us are very familiar with antibacterials, their uses, appropriate uses, inappropriate uses. When it comes to antifungals, particularly in the management of invasive fungal infections, the knowledge may be lacking in many places, particularly among the non-infectious disease physician groups. So we'll start talking about this. Let's go to the next slide. Fungal infections are very, very unique, okay? And I sat down and I wanted to list all the reasons why the fungal infections are so different from bacterial infections and what may be the reasons, or what are the things that distinguish fungal infection from bacterial infection. Here I came up with this list, and I can tell you this is only a partial list. You can see there is increasing prevalence with morbidity and mortality, particularly in low-income countries. There is a lot of data. For example, in India, if a person develops invasive fungal disease, his chances of dying are higher as compared to the same infection in a place like the United States. Okay, so no uniform distribution across hospitals, and many of these fungi are soil-based. So depending on the geographic area, if that particular soil has a lot of that particular fungus, then those fungal infections would be more common in those areas. So that's why we say some of these fungi are endemic fungi to certain parts of the world. In bacteria, we don't see that commonly, such a endemicity, okay? And in medical schools and training programs, fungal infections don't get the same degree of attention that bacterial infections get. So the lectures are fewer, the attention is much, much less, both in the medical school curriculum as well as in postgraduate training programs when it comes to fungal infections and antifungal drugs. And fungal infections are very non-specific. There's nothing that is very unique or pathognomonic for a fungal infection. And they are underappreciated, people. It doesn't come into your radar that I should be considering a fungal disease when you're standing at the bedside. And the number of tests available are limited. There's frequently, as a result, as a delay in diagnosis, contributing to higher mortality. And many of us are afraid we're going to miss a fungal disease, and therefore we starting empirically, even without sufficient data. And the drugs available are limited. There are over 400 drugs US FDA has approved for bacterial disease. But how many do you think are available for fungal disease? Less than 20. Okay, so the drugs limited, and many of these drugs like amphotericin have increased toxicity. The cost is very high in many of these low-income countries, particularly the newer antifungal agents. And resistance is beginning to be reported for a variety of different antifungal drugs in many parts of the world. And these are all very difficult to test. In vitro testing is not freely available, as we do with bacterial infections and bacterial pathogens. Overall, antifungal resistance knowledge is poor. So if you stand and look at all these different things, fungal infections are very, very unique, and they are far behind in terms of appreciation by the treating physicians. For all these reasons, I think we need a good stewardship for appropriate use of drugs at the bedside. Next slide, please. So what is the definition of antifungal stewardship?
Any other participants? So if there are no questions.
Okay. What about, I plugged into the AI and I wanted the definition. I looked at the definition of antifungal stewardship. It's a very nice definition. Let me read with you. A coordinated program of interventions, appropriate use of antifungal medications, aiming to improve patient outcome, minimize adverse events and drug interactions, combat antifungal resistance, and reduce cost. So it's pretty comprehensive. In order to achieve this, we need multidisciplinary teams working to optimize choice of antibiotic, dose, route, and the duration. So there's a very comprehensive definition. The important terms that I would like you to take away from this is a multidisciplinary team that is going to be necessary in the hospital to practice good antifungal stewardship in order to achieve good patient outcome, decrease drug interaction, minimize toxicity, and overall reduction in the cost. Next slide. Next slide, please. Okay, so when you look at the literature, there are two major infectious disease bodies that have come up with core recommendations. One is the Mycosis Study Group Education and Research Consortium, and the other is IDSA, or Infectious Disease Society of America. There are published recommendations what an antifungal stewardship ought to be, and these are done by these two organizations. But they are primarily designed for Western part of the world. So obviously, these have to be modified to make it suitable for the Asian condition. Next slide. And that's what happened with these papers here. So there are two publications here. One is published in a journal called Expert Review of Anti-Infective Therapy in August of this year. And the lead author is Dr. Arunalok Chakrabarty, who is a leading mycologist in India. And he brought together a team, and the team of people got together and wrote guidelines for antifungal stewardship suitable for the Asian situation. And the next document you can see there is Antimicrobial Resistance Stewardship Working Group. That got together and came up with a practical guide to implementing and improving antifungal stewardship programs in hospitals. So these two publications are the basis of my talk. So most of the slides I have prepared are obtained from these two publications because this is a talk that I'm giving for the Asian audience. So the stewardship should be relevant for the Asian group. Next slide, please. So these come up with 7 key steps that would constitute the core program components in antifungal stewardship. Engagement of senior leadership, accountability and responsibilities, expertise in infection management, education and training, promote responsible antifungal use, monitoring and surveillance, reporting and feedback. So the guideline group sat down and wrote down these to be the main steps or the cornerstones of a good antifungal stewardship. So the rest of my talk, I'm going to talk about each one of these in the Asian situation. Okay, 7 key steps. Next slide, please. So these are the 7 program components. The 7 are shown here, and we'll go one by one, and you will see how they all are interconnected so that we have a very effective program for any given hospital at the end of the day. Next slide. Okay, step 1. Number 1 is engagement of senior leadership. Those of you who are working in hospitals will realize right away, if you want to have a policy implemented in a hospital, you need the support of the administration. Without the administration support, you cannot introduce a policy which may be acceptable to people or may not be acceptable to everybody in the hospital. But because the senior administration insists that policy has to be implemented and followed, then everybody would toe the line. So for that reason, if you want to have a good antifungal stewardship, you have to have support of the senior leadership. Without the support of the administration, you cannot have an antifungal stewardship. And this is not easily attainable because the senior leadership would say, I don't want to antagonize senior physicians, or I don't want to bring something that may cost money for the institution. So we need to be able to convince the administration that this would enhance quality of care and ultimately it would save cost for the hospital. Okay, so engagement of senior leadership is of paramount importance in antifungal stewardship. Next slide, please. What about the Asian perspective? There is such decreased awareness of invasive fungal disease at all the levels. Right now, only about 30% of the Asian hospitals have antifungal stewardship programs. And there is no population surveillance of invasive fungal disease or resistance. So this is a problem. Without data, it's very difficult for the Asian hospitals to function. So this is a deficit that ought to be corrected. What are the possible solutions? The experts in the group came out with these following recommendations. Increase the awareness among hospital authorities. So those administrators who are not physicians, they need to be educated on the importance of fungal infection and the importance of antifungal drugs, and collect data to show that eventually there could be cost savings and better outcome with the use of a stewardship program. And identify people who are antifungal stewardship champions among the physicians, among the pharmacists, and that would hopefully increase the awareness of the importance of antifungal stewardship. Associate with existing antimicrobial stewardship programs. So there may be programs within the institution of antimicrobial stewardship, but not antifungal stewardship. So antifungal stewardship can dovetail with existing antimicrobial stewardship as a subcommittee of the AMS, and therefore can bring about antifungal stewardship. If antifungal stewardship by itself cannot survive, or it may be too expensive to have such a program. And then you can collaborate with other existing committees in the hospital and also promote accreditation for both antifungal stewardship and antimicrobial stewardship. So these are all some of the solutions. The Asian experts got together and said these would be good solutions for any hospital, medium-sized or large hospital, in an Indian setting to bring about a successful antifungal stewardship. Next slide, please. Let's go to step 2. What is step 2? Accountability and responsibilities. The recommendation by the Mycosis Study Group Education Research Consortium said there needs to be a multidisciplinary team. And the team will have strong in-depth knowledge of invasive fungal disease, frequently consisting of ID experts and ID pharmacists. And these people will engage with key practitioners who are encountering fungal disease frequently in the hospitals. Get them involved through grand rounds and other means, engage the key practitioners practicing in the hospitals. So the next slide shows you a picture. Next slide. Here you can see who are supposed to be a part of an antifungal stewardship team. You can see here there is a team leader, and usually it's an ID trained physician, and an ID trained pharmacist would be the right-hand person for this team leader. And then you think about the hospital and say, what kind of doctors in the hospital are frequently seeing fungal infections? Transplant physicians, both solid organ and stem cell, hem-onc specialists, maybe general surgeons. These are the guys who may be encountering fungal diseases. Bring them into the antifungal stewardship team, as they are frequently prescribing antifungal drugs, pharmacists and microbiologists. So these would be the different groups of individuals that would usually form an antifungal stewardship team. Next slide. But in the Asian situation, you can see there are many, many limitations. There are very few people with medical mycology knowledge. There are many hospitals do not have ID specialists, and there are multiple specialists managing IFD, too many people. So bringing them all into the team may not be possible. Many, many physicians use these drugs empirically without adequate evidence of an antifungal fungal infection. Therefore, they may be using the drugs empirically in a wrong way. And many times, invasive fungal disease mimics tuberculosis, and the diagnosis may be missed, and the treatment may be inappropriate. So these are many problems in the Asian setting that have to be taken into account when we are dealing with step 2 and trying to build a core team within the hospital. What are the solutions? Next slide. Here are the possible solutions for the Asian scenario. A antifungal stewardship team, find an MD or pharmacist with a knowledge of fungal infection, bring them into the antifungal team, promote educational programs on antifungal infection, antifungal drug therapy, stewardship principles, maybe have telehealth use, bring outside ID experts. If you don't have your own in your hospital, bring them on telehealth, such as what we are having right now here. Local guidelines based on local epidemiology. So the hospital needs to know the local epidemiology of the fungal diseases. Accordingly, perhaps create local guidelines that can be spread throughout the hospital, and gradually work with the administration to bring more ID physicians and ID trained pharmacists and give them enough time to be able to practice antifungal stewardship. So these are some of the suggested solutions to address the Asian limitations in having a good core team for accountability and the responsibility towards a stewardship team. Okay, that is step 2. Let's go to step 3. Expertise in infection management. This is what we call diagnostic stewardship. The recommendations are, if you have centers managing invasive fungal disease, they should have access to timely, conventional, and non-culture-based diagnostic tests for two primary fungal pathogens, namely Candida and Aspergillus. And we all know early, accurate diagnosis impacts appropriate drug therapy and the outcomes. That is the cornerstone. Early, accurate diagnosis is critical. For that, we need to have good conventional tests as well as non-culture-based molecular tests available in a timely manner so we can make the diagnosis on time. And these could be conventional tests are usually microscopy, culture, and histopathology. These are available as standard tests in many, many hospitals. However, they're not very sensitive. It takes a longer time for results to become available, and it's pretty labor intensive. And many times we have to obtain tissue to perform histopath or culture. And for that, it will be invasive procedure. In these sick patients, it may not be easily doable. Therefore, we need non-culture tests, such as serological tests, or more recently, molecular tests using things like PCR. And these should be standardized tests, become available at the point of care in the hospitals so that we can make a timely diagnosis. So this is very important diagnostic stewardship. Next slide. So this is what the recommendations are. For example, look at Candida. What should be the tests that we should be having available in the hospital? Gold standard is the blood culture, but only 50% of the sensitivity. So it's not adequate. So what are the new things? In the United States, we have something called MALDI-TOF. It's a spectrometric test to improve identification faster for blood cultures. So this MALDI-TOF has become widely available in most of the hospitals in the United States. So for early identification of pathogens in the bloodstream. And multiplex PCR has also become widely available for many of the common fungi clinically seen. 1,3-beta-D-glucan or BDG is available in many hospitals, and this is an important constituent of the cell wall of many, many fungi. So looking for the presence of beta-D-glucan will indicate the possibility of invasive fungal disease, particularly Candida, okay, if there is a deep-seated infection. And then there is something else called T2 magnetic resonance test for early identification of Candida. So not all of them are available in all the hospitals, but this is the ideal for improvement of diagnosis of invasive Candida. For Aspergillus, next slide. These are the different tests that a hospital should strive to have. Okay, you may not have it, but you can fight with the administration. The core team has to recognize that without these tests, it may not be easy to identify quickly Aspergillus infection in your patient. The gold standard, of course, is taking tissue, putting it under the microscope, and directly visualize branching septate hyphae suggestive of Aspergillus. And then there are other tests, what we call serum galactomannan antigen detection. It's an ELISA test, but now there are point-of-care lateral flow devices which make the test very, very inexpensive. So the core team has to fight with the administration and say, let's bring these inexpensive tests to our hospital so we can make a diagnosis. So 1,3-beta-D-glucan, galactomannan antigen, molecular tests like the PCR, high-resolution CT of the chest. Aspergillus is predominantly pulmonary, and therefore CT chest becomes a very important tool for identification of pulmonary abnormalities that would suggest pulmonary aspergillosis, maybe pulmonary angiogram in certain hospitals to improve, again, early identification of Aspergillus. These are the diagnostic tests that we use. Next slide. But what are the limitations in Asian hospitals? It's a problem. inadequate lab facilities. Nobody says fungal tests have to have a separate lab. Most labs don't have the equipment, don't have the space, don't have the money. And there is very limited access to molecular tests. And all these take a long time before the results become available. These are major limitations in Asian hospitals. So what are the recommendations? We need to have conversations, integrate resources. Maybe in a city, instead of every hospital having a molecular lab, maybe there could be one centralized lab that would receive specimens from all the hospitals and process them, so duplication of work is avoided. So centralizing lab for molecular tests is something the hospitals within a region can consider. And they need to provide timely testing, getting the specimens on time and getting the results out on time. Point of care, wherever possible, the test has to be performed at the point of care, and they should be cheaper, and there should be little equipment needed to perform such point of care tests. Or in the absence of these tests, clinical predictive rules to enhance the diagnosis as accurately as possible. And criteria that are simple for diagnostic purposes, one could create, and these could act as surrogates for a good test if you can't have the good test. So these are all some of the solutions offered by the experts for the Asian hospitals that may have these limitations in bringing good diagnostic tests. Step 4. Next slide. Education and training. This is a major point. We need to educate ourselves, educate our hospital authorities, educate the public in these various areas. And these have to be repeated because people keep changing. People change jobs. People move out. So they have to have constant education programs to cover all the knowledge gaps, not caps. Interpreting the lab test, distinguishing which specimen result is a colonizer, which is a true infection. When do we start empiric therapy? There is a tendency, and because of the lack of diagnosis, to start empiric therapy too soon. So we need to have well-defined indications. When is it reasonable to start empiric therapy? When is it reasonable to give prophylaxis? Otherwise, there will be a lot of abuse of these products. And how do we dose them? And once we start the drug, how do we monitor them? All these things, there are knowledge gaps, and education on these points have to be clearly made for a variety of different physician groups as well as the hospital authorities. Next slide. Asian perspective, there's very little mycology knowledge at this time, very little time spent at the MBBS level or at the MD level for antifungal drugs and invasive fungal disease. And that deficit has to be corrected. Lack of ID physician use in managing IFD. There's a limited number of ID physicians around the country, and even they are not approached by the other specialists when they encounter fungal disease. So those ID physicians have to be made use of to say, hey, come on here. We have a patient with invasive fungal disease. Please give us a hand. How to optimally manage this patient. So what are the possible solutions? To increase the awareness, you can create pocket cards, local guidelines, free online resources to be made available to everyone, training in institutions with antifungal stewardship, advocating mycology education for undergraduates as well as postgraduates, training the trainers with interactions, workshops, frontline physicians, train them when is it appropriate to ask for an ID consult, and certification of prescribers and periodic recertification of these prescribers. All these can constitute as possible solutions to to improve the awareness in terms of fungal disease and appropriate antifungal use. Okay, next slide, please. Step 5. Promote responsible antifungal use. Recommendations here again: seek ID consult for IFD, invasive fungal disease. Care pathways can be created. Bundles of care for treatment of Aspergillus or Candida can be created. I'll show you a couple of examples. Post-prescription review and feedback. Regular evaluation of quality of antifungal prescribing on a systematic basis to optimize. This would help optimize intervention with antifungal stewardship. All these, after the diagnosis is made, seeking ID consult for management and creating treatment bundles are important in order to use these drugs in a responsible manner. Next slide. Here are the treatment bundles for Candida. So this bundle can exist in the hospital. For example, if you say you have a patient with Candida and you're starting therapy, make sure you have high volume blood cultures, remove existing central venous catheters. They may be the source of the Candida infection. Initial appropriate selection and dosing, considering local epidemiology, started within 12 hours of culture. Eye exam to make sure the Candida has not spread into the eye. All these would constitute a bundle of care for patient suspected to have invasive candidiasis. So this would become a routine practice for every case of Candida infection, systemic Candida infection. So after starting therapy, again, you can have these bundle. These are the different components. Follow up blood cultures daily until candidemia is cleared. Echocardiogram in the appropriate patient population. Clinical efficacy assessment in 3 to 5 days to see where we are at with the patient. Complete at least 2 weeks of therapy after clearance of blood cultures. So the treatment will be of adequate duration, and stepping down from IV to oral in the appropriate setting. All this will constitute treatment bundle. So one should consider bringing them in to your hospital as a treatment bundle for invasive Candida. Next slide. Likewise, next slide, please. For Aspergillus, there could be treatment bundles and at the start of therapy and after starting therapy. All these could be important components. But I'm not going to read every line here. And these are just examples to show that if you have treatment bundles in a hospital for specific invasive fungal disease, it makes it a lot easier. Okay? You don't overlook something or forget something. Next slide. Step 5, Asian problem. Obviously, there is not enough local national guidelines. Antifungal drugs are not readily affordable 80% of the time. It's not available. It's only 34% of the time it's available. So these are limitations with patient situation and lack of clinical decision support system. The support system is not there. So what are the solutions? You can develop local guidelines through the core team, available, make it available within the system, and they should be simple, practical, and easy to follow, appropriate for the local scenario. And whatever antifungals that are available, optimize the use of them, such as azoles and conventional amphotericin B. Not every time you need a lipid formulation of amphotericin B. And face-to-face interactions. After you have prescribed, go back and see what has happened to the patient. And feedback to the prescriber is critical. And sometimes you can even have, when somebody requests a drug, review the product and see whether it's appropriate or not, the request. So that could be a pre-authorization approach. Okay, all these could be possible solutions put out by the experts in the Asian setting where there could be limitations. Next slide. We're getting towards the end. Step 6 and step 7. Step 6, now you have started the treatment. You're monitoring the patient is very important. And the recommendations are the centers that have invasive fungal disease establish local surveillance systems for invasive fungal disease. So there should be a constant surveillance within the hospital and collect data for patients with invasive fungal disease. Have timely antifungal susceptibility tests. So in those patients with proven disease, we need to provide susceptibility data in a timely manner and develop cumulative antifungal susceptibility reports over a period of time. And there should be a mechanism with the help of the pharmacy, with the help of the microbiology lab, these antifungal susceptibility reports can be created, perform rational diagnostic tests, and convey results to the stewardship team in the hospital. And medical records, medication records have to be screened to make sure there are no drug interactions. That's where the pharmacist comes in, and have access to timely therapeutic drug monitoring. Maybe the drug levels have to be measured for things like voriconazole when you're using that drug. So all these principles have to be implemented in centers managing invasive fungal disease, and these have to be made available. Next slide. What about the Asian situation? You can see population-based surveillance is lacking. There is no routine antifungal susceptibility test in more than 40% of the regional labs for yeast. For mycelial organism, there are only 27% labs in India that provide antifungal susceptibility tests. So there's a serious limitation if the labs are not available to perform susceptibility testing. Valditov that I mentioned, sequencing is not available, PCR test is not freely available, and galactomannan is not readily available with a good turnaround time, and there is very little use of therapeutic drug monitoring of drugs like the azoles, the accessibilities. And these are limitations. So what can we do? Improve the infection control procedures, identify the patients for therapeutic drug monitoring, culture and identify the fungal pathogens, and try to avoid self-medication. There's a tendency in Indian patients to self-medicate themselves. And that needs to be avoided or prevented through education. Education, education, education is the key to improve these problems that we have today in the Asian hospitals. Next slide. Step 7, the final step, reporting and feedback. Mechanism so the recommendations nationally, a mechanism to track antifungal drug use, benchmark antifungal use, helps in the antifungal stewardship, assess patient level outcome, and then provide the feedback for the prescriber. So these are very important steps, the national recommendation. And the drug consumption has to be measured either as DOT or DDD in many, many hospital situations. And these, next slide, please. And these may be lacking in the Asian situation. Collecting metrics in antifungal diseases and antifungal drugs is very, very limited because most hospitals don't have electronic data system. And that has to be rectified. Electronic data systems need to be brought in to many of the hospital situations and fight for funds to improve healthcare technology. And this healthcare system is broken up, and that fragmentation needs to be fixed in order to address these limitations. So use the available metrics, and you can perform, even in the absence of good metrics, you can perform point prevalence surveys to what's happening at that point in time. That doesn't require a whole lot of new technology. Tracking patient level outcomes and accessibility of reports, and most importantly, getting the feedback to the prescriber is absolutely critical. Next slide. So the summary slide is knowledge of fungal infection, diagnostic tests and optimal use of antifungals is critical at all levels, not just the doctor, but among the pharmacists, among the hospital authorities, and all those involved in the care of the patient, and importantly, the patients themselves, so they can take charge of their care as well. Good antifungal stewardship leads to good patient outcome, reduced resistance, and importantly, cost as well. And that has to be conveyed to the hospital authorities so they become part of the core team. Teamwork is paramount. And who would be the leaders of the teamwork? It would be the ID physician, who is knowledgeable in invasive fungal disease, and the pharmacist, who is trained in infectious disease-related drugs. And these would be the champions. But not every hospital has an ID physician or a pharmacist. So who do we go to? Within that hospital, you identify those who are interested in infectious diseases, those who prescribe antibiotics most commonly. They assume the role of champions, because not every hospital in India has an ID doctor or an ID pharmacist. So that is another limitation. We need support of senior leaders in administration. Antifungal stewardship, at least, can become a part of antimicrobial stewardship. There may be money for antimicrobial stewardship. There may not be money for antifungal stewardship. Therefore, antifungal stewardship can become a subcommittee within antimicrobial stewardship, and that the hospital might allow to have. And finally, if the smaller hospitals, it may be run by ID physicians alone or by the pharmacists alone, again, depending upon what kind of support the hospitals have. So I hope this, for the listeners, I didn't present cases, but I thought this would be a good way to introduce the components of good antifungal stewardship and how, in the absence of ideal situation, how you can function in a hospital to provide optimal antifungal care to our patients. Thank you. I think I'll stop there.
Thank you, sir. Thank you, sir. I think there are many times even the antimicrobial and antifungal stewardships are part of the program majority of the time. And most hospitals, except those who have a lot of transplant going on, there's not much use of antifungals. Except that recently there's a lot of use of antifungals in ICUs in India, primarily because majority of the patients who are getting admitted in ICU are getting some immunosuppression in the form of steroids or some other thing. Like a lot of these tropical infections do get some steroids. So there are trends where there's an increased usage of antifungals in many Indian ICUs. And as you are aware that there's increase even in Candida auris cases across India. So our own hospital, we don't use much.
Sorry, you're right. It's the best place to look for fungal diseases, primarily candidiasis, is in the ICU. In the ICU, it may be line-related. It may be more immunocompromised patients are all concentrated. There are more devices there, and therefore one would expect to see invasive candida in that setting because of increased antimicrobial use, etc. So the intensivist, if there is one in the hospital, would become an important player as a co-member of the team.
Venkat has a question. Empirical treatment with wide discharge PV with fluconazole is common. He wants you to comment on it, sir.
Yeah, these are all problems. I can tell you this happens in America too. It's not very unique. People are lazy. Physicians don't want to perform a good pelvic exam. They don't want to obtain the specimens. They're not very well trained. So they listen to the symptom of the patient. over the telephone and prescribe the drug. And white discharge is an extremely common situation, which ideally fits this example. So it's a problem. What can we say? Physicians have to be better trained. They have to examine the patient, encourage patients to come to your clinic, and you have to know how to examine and how to make a diagnosis. You need to know the fundamentals of white discharge per vagina. So unless it begins at that level, you're going to promote empiric use, and the patients will get used to the same, and the patients will also expect the same from you. So this is not an overnight solution. This is a major problem. Education and training is the main key.
So the next question is, what is the interval at which the blood culture is to be sent following up invasive candidiasis? When should the next blood culture be drawn after starting treatment? One of the
In
questions.
general, invasive candidiasis, as I mentioned, the blood cultures are positive about 50% of the times. So if the blood cultures are positive, these are patients who are candidemic with systemic candidiasis. And those candidemic patients, we are lucky that we have something to monitor, which is a positive blood culture. And therefore, the blood culture should be obtained every day until the blood culture becomes negative. So, just like Staph aureus bacteremia, daily blood culture would be the ideal management in the management of systemic candidiasis with candidemia. So the recommendation is to obtain daily blood culture until clearance of the blood culture. It's an important, very important principle because Candida has a propensity to produce metastatic sites of infection. So from the bloodstream, it can get into the eye, it can get into the spine, it can get into the renal cortex, it can get into diverse areas to produce metastatic sites of infection. This is why we say, even after the blood culture is cleared, make sure the treatment is continued for another 2 weeks in order to get to metastatic sites of infection and eradicate those sites of infection. I hope I answered the question.
Yes, sir. Yes. The next question is, what is a drug recommended for vaginal candidiasis in pregnant women resistant to fluconazole?
Well, let me see. Where is the question?
In the chat, sir.
Yeah, I'm looking
in the
in the
chat box, sir. Yeah, drug recommended for vaginal candidiasis in pregnant women, but fluconazole resistant. They have not mentioned the species.
I don't know. I'm not a Candida vaginitis expert. My colleagues in fluconazole resistant situations, they would use what they call boric acid. Boric acid is a drug that they use every now and then for fluconazole resistant cases. But these are situations where I would say they should go to the gynecologist who may be well versed in this area. Okay, let me keep going through quickly. Beta-D-glucan role in candidemia. Yes, beta-D-glucan can be positive. It's an indication of, it's a fungal cell wall constituent, and its presence indicates candidemia. And if it is present and it's high, you can monitor the beta-D-glucan, which will gradually decrease over time with treatment. So it plays a very important role. So absence of beta-D-glucan is a good indicator of the absence of systemic candidiasis. It has a very high negative predictive value, not positive predictive value. Voriconazole trough should be checked weekly once, and aspergillosis comes positive in galactomannan and BAL. What's the question there?
What's the duration of worry, sir? He wants to know what is the duration of worry
worry.
in,
Okay,
in
patients
bowel
with
fluid, yeah. invasive fungal infection of the lung. That's what
Yes.
duration is asking.
So pulmonary aspergillosis, how long should it be treated? Usually, in pulmonary aspergillus treatment or aspergillus treatment, there are three things you want to pay attention to. One, is there clinical improvement of the patient? Two, is there radiologic improvement of the patient? And three, is the immune system being rectified? So these are the three things that would help you determine the ideal duration of treatment for pulmonary aspergillosis. In general, the minimum treatment is not less than 4 weeks for pulmonary aspergillosis. However, the 4 weeks is modifiable based on clinical, radiological, and immunological improvement. Symptoms and signs should have been abated. Radiology, there should be considerable improvement on the CAT scan. And three, the patient is neutropenic. The neutropenia should have been resolved. The patient is on corticosteroids. Ideally, the corticosteroids should have been taken so that the immune system is normalized. So these are the three things we take into account to determine the duration in individual patients.
In India, is it possible to send blood cultures daily? Yeah, it's a challenge, definitely. So we tend to do it once in 2 days or sometimes 3 days. But the problem of doing that is you'll get your reports later, so you end up stopping your drug much later. So that's always the challenge. But you have to balance out. In an ICU patient should not be a challenge because most of them are sedated on ventilator. Somebody who is in HDU fully conscious, I think there's a challenge in that. And drawing blood from lines will be difficult to interpret. So ideally it should be from the periphery. I think Venkat has already quoted serum
Many
galectin is
non-neutropenic
double-edged
patients.
sword, non-neutropenic. So this last question, do we need to treat non-candida albicans in urine culture? If so, what is the dose of fluconazole? I think sir's favorite question this is. Sir,
Well,
go ahead,
do we need to treat non-candida albicans in urine culture? Candiduria is an extremely common situation, and most of the times it doesn't require therapy. Most of the times it simply represents colonization, and therefore one has to be very, very careful before you decide to treat the candiduria as a possible candidal urinary tract infection. So once you decide treat the candida, and if it is candida albicans, most candida albicans are fluconazole susceptible, and fluconazole reaches very high concentrations in the urine. That would be the ideal drug. If it's a non-candida albicans, we're down to susceptibility testing. And without susceptibility testing, it's going to be very difficult to guess which one may be. Even glabratas at our institution, Candida glabrata, only 40% of the times it's fluconazole resistant. 60% of the times I can treat the glabrata with fluconazole. So without susceptibility testing, it would be very difficult to guess what drug should I be using for cases of non-albicans candida.
Yeah, I still remember when I visited Dr. Jock Sabel has written one very nice article on Candida, how to interpret and treat it. It's about 10 years old probably. It's a wonderful article. I think I should
Yes,
have
there are several articles to show with treatment and without treatment, the outcome is exactly the same with candiduria. And even after you treat and you eradicate, within 2 weeks, the candiduria recurs in the same patient. So it is pointless to treat the candiduria. It's the last one.
Yeah, I think that should be the last one, sir. Kavita can give concluding remarks.
Thank you, Dr. Chandra. It was a wonderful step-by-step approach to antifungal stewardship, and you have highlighted the engaging administrative people and teamwork, and also the importance of diagnostics, because only if we have diagnostics we can be or tailoring our treatment and practice the stewardship principles. And also highlighting education, awareness, and also the clinical care with the appropriate use of antifungals. Thank you very much for this wonderful step-by-step approach. It's ready to use for anyone who is willing and has the infrastructure. But first of all, willingness to adopt. Thank you for the wonderful session and for answering all the queries very patiently. Also, I appreciate Venkat for a very methodical lecture, emphasizing physical examination of all patients, going for the syndromic approach for infectious diseases, and targeting the antibiotic to the accurate drug dose and duration, and most importantly, source control in all cases where there is a foci of infection and deep abscesses. Excellent talks by both the speakers. I'm very, very satisfied with the today's webinar. And this webinar is brought to you by Manipal Center for Infectious Diseases and the Department of Infectious Diseases at Kasturba Medical College, Manipal. Today, we completed the 5th day of World Antimicrobial Awareness Week. And going forward, we have one more day tomorrow, and we will have lecture on making sense of culture and AST reports, and also pharmacokinetics and pharmacodynamics for clinicians. So do join us, and I thank all the attendees for joining us on all these dates, and I urge all of you to take home these wonderful messages and put it into your clinical practice. And thank you, Dr. Verma, for moderating the session beautifully. Thank you very much.
Thank you, ma'am.
Thank you.
Thank you.
Thank you. Thank you, everyone.
Thank you.